Welcome to your NICU rotation. We look forward to working with you during your month with us. This orientation presentation is part one of a four-part series designed to prepare you ahead of starting your rotation with us. In this presentation, we will discuss general expectations and workflow in the NICU. The topics covered in subsequent presentations include an overview of normal and abnormal vital signs in the NICU, interpretation of common laboratory tests performed in the NICU, and how to calculate fluids and nutrition for neonates. The main goal of the NICU rotation is to train those who will be responsible for the care of well newborns and for resuscitating and stabilizing sick newborns. Even if you do not want to pursue neonatology as a career, many community-based pediatrics and family medicine jobs include delivery room and well baby coverage as part of their responsibilities. We believe that having knowledge of perinatal physiology and pathophysiology will aid in the development of skills that generalists need for identification of neonatal illness, resuscitation and stabilization of the neonate, and provision of care to the NICU graduate in their practices. Detailed goals and objectives can be found on SOL or the eValue websites. Neonates are assigned to one of three NICU services based on their acuity and/or medical problems. Patients can be found on the following NICU system lists. Neonatal 1 or NN1 is for those neonates requiring intensive care or for new admissions. These patients are typically located in pods 1, 3, 4, 5, and 6. Neonatal 2 or NN2 is for those neonates that are convalescing and are step-down status. These patients are typically located in pods 7 and 8. Neonatal 3, or NN3, is for those patients requiring more long-term care for bronchopulmonary dysplasia, or BPD. These patients are typically located in Pod 2. In addition to division of patients to these different services, the patients are also divided between two rounding teams, the neonatal nurse practitioner, NNP team, and the resident team. Even though these patients are separated onto these two teams, each group should be willing to help the other. The resident physician team has a cap on the number of patients that it will carry in order to balance educational goals of service and learning. When the resident physician team is composed of entirely WVU, pediatrics, or combined med-peds residents, the patient cap is 24. When the resident physician team is composed of a mixture of WVU, pediatrics, or med-peds residents with visiting residents from UHC or Harper's Ferry, the patient's cap is 22. The resident team will take care of neonates born at 28 weeks postmenstrual age or greater. Neonates less than 28 weeks gestation are cared for by the NNP team. Despite these caps and gestational age restrictions, the team should always be willing to assist with admissions and patient care, as there will be the potential for significant learning opportunities missed. This is the typical daily workflow in the NICU. Morning checkout from the overnight NNPs occurs at 7 a.m. Pre-rounding on NICU patients occurs between 7 and 8 a.m. At 8 a.m., there is pediatrics morning report, which should be attended. Bedside teaching rounds take place between 8:30 and noon. Make use of the computers on wheels during rounds to place orders so that elements of the daily plan do not get forgotten and can be clarified on the spot. This is particularly true for TPN and feeding orders. At noon, there is Pediatrics Noon Conference, which should be attended. In the afternoon is time for completing daily progress notes, updating families, and self-directed learning. Typically, only one member of the resident team stays late each day until evening checkout, which occurs at 7 p.m. Other tasks such as deliveries, admissions, procedures, and family meetings can occur at any time throughout the day. In the following slides, some of these items will be discussed in more detail. While morning checkout should occur no later than 7 a.m., it is a good idea for you to get checkout about your team from the overnight NNP when you arrive. Both morning and evening checkouts occur in the NNP office located inside the NICU. Evening checkout to the overnight NNPs should include both verbal and written handoff. The iPass format is used for this handoff. The main point of pre-rounding is to prioritize patients' problems based on acuity and to gather pertinent information needed to synthesize a plan of care for the day for each neonate. The components of pre-rounding include reviewing the notes and data in the patient's electronic medical record, getting the numbers for fluid and nutrition intake, talking to the patient's bedside nurse, and examining your patients. Reviewing notes can provide good insight into events that occurred in the overnight period that can significantly change the plan of care for an infant. For example, an infant on no supplemental oxygen or respiratory support and feeding from a bottle has several apneic events or increased work of breathing and is made NPO, started on CPAP, and started on antibiotics. This change could significantly alter your plan of care for the day. Gathering clinical data to present on rounds will be covered in detail in subsequent presentations. I cannot stress the importance of forming good working relationships with the NICU nurses enough. In no other unit in the hospital is it as important as it is here. They are the backbone of our team in the NICU. Our nurses are extremely knowledgeable about the care of these infants and can provide significant insight for you with respect to interpreting clinical data, physical exam findings, and developing plans for the day. Work with the patient's bedside nurse to find a time for assessment. Asking if it's okay to examine a baby is good and a polite thing to do. It is not critical that you examine every baby before rounds. In fact, for some babies, like those with neonatal abstinence syndrome, their care should be bundled around times of feeding or receiving treatment. Certainly, if assessment is needed for an acutely ill patient, then do the assessment. Develop a plan of care with the bedside nurse. Many times they will know if a baby is ready to wean from CPAP to room air, advance on feeds, or have their dose of morphine decreased. You just have to ask. Pediatrics morning report and noon conferences should be attended and are required for WVU Pediatrics and MedPeds residents. Morning report starts at 8 a.m. and noon conference at noon. If morning bedside teaching rounds are approaching noon, please let the NICU fellow or attending know so that arrangements can be made for patient care and conference attendance. Neonatal didactics are on Thursday afternoons from 1 to 4 p.m. While these are primarily geared towards the neonatal fellows, you are invited to attend and serve as a good learning opportunity. Deliveries can occur at any time throughout the day. We have placed an emphasis on residents being able to lead resuscitations for term and late preterm infants, as these are the most likely deliveries you would be expected to attend in your future practice. NICU involvement at a delivery is documented by completion of a procedure note. The type of procedure note filed differs based on what interventions are used for the newborn. If CPAP, PPV, or more advanced resuscitative efforts are required, then a delivery room resuscitation note should be completed. In the new note, choose procedure for the note type and neonatal resuscitation for the procedure name. The note template can be accessed by typing resus in the smart text box and choosing delivery room resuscitation. If the newborn requires only drying, stimulation, and at most blow-by oxygen, then an attendance at high-risk delivery note should be completed. In the new note, choose procedure for the note type and attendance at delivery for the procedure name. The note template can be accessed by typing attend in the smart text box and choosing attendance at high-risk delivery. Like deliveries, admissions to the NICU can occur at any time throughout the day. Always be willing to help with admissions, even if your team is at its patient's cap, because these are great learning opportunities and great opportunities to work together with the NNPs as a NICU team. You can always help with placing admission orders, completing notes, or aiding in necessary procedures. There are 2 order sets to aid the process of admitting a newborn. These can be accessed by typing NEO admission into the order entry area. There are two general order sets, one for newborns with a birth weight greater than 1.5 kilograms and one for those with a birth weight less than 1.5 kilograms. While the time around an admission can feel very fast-paced, it is important for your learning to use this time to identify the patient's medical problems, formulate a differential diagnosis that will then guide your diagnostic workup and management plan. During your NICU rotation, there will be opportunities for you to learn and improve upon your procedural skills as it pertains to newborn patient care. While it is impossible to predict what mix of patients and procedural opportunities will be present in any given month, it is our hope that you would have exposure to this list from the ACGME pediatrics requirements. From the ACGME in July 2019, residents must demonstrate procedural competence by performing the following: bag mask ventilation, lumbar puncture, neonatal endotracheal intubation, peripheral intravenous catheter placement, umbilical catheter placement, venipuncture, and neonatal resuscitation. This list must be balanced with the reality that as a field, we are intubating less neonates and placing umbilical venous catheters with less frequency. The ACGME also provides a secondary list of procedures that could be pursued by residents seeking a post-residency position where these skills would be needed. These procedures include arterial line placement, arterial puncture, chest tube placement, circumcision, and thoracentesis. Access to these procedures can occur in a real or simulated environment. Again, there should be recognition that these procedures occur with even less frequency than those on the required list from the ACGME, and performing these procedures on real patients should be reserved for those pursuing a position in which they would be required, such as neonatology. Each patient will need a daily progress note. The template for the daily progress note can be accessed by using the dot phrase .NICU res prog. As much as possible, avoid copying forward daily progress notes. This creates a largely unusable, confusing note that sets the stage to carry forward inaccurate information or carry forward problems that have long been resolved for the patients. There are specific note templates to be used for the discharge of newborns from the NICU. On the day of discharge, a day of discharge progress note will take place of your regular daily progress note. For the discharge summary, the auto-populated note from the hospital system should be cleared, and instead a specific newborn discharge summary should be used. These note templates can be accessed by typing NN-DIS in the smart text box. Discharge summaries must be completed on the day of discharge, as our patients will be following up with their primary care physicians in 1 to 2 days, and the system will need this amount of time to get the discharge summary to the PCP. There are many good resources for reviewing neonatal procedures. These are links to YouTube videos to review procedures like umbilical catheterization, intubation, and lumbar puncture. In the afternoon, while waiting on evening checkout, there can be large amounts of downtime once progress notes, procedures, and family updates have been completed. This is a great time for self-directed adult learning in the NICU that will supplement the bedside teaching and short teaching sessions provided by the NICU attendings and fellows. 3 resources are presented here. The AAP Committee on the Fetus and Newborn publishes clinical practice guidelines and policy statements that can be found on the AAP website or put together in the Neonatal Care Compendium. A copy of this can be found in the NNP office. There are neonatal texts that can be accessed through Clinical Key on the WVU library website. Clausen Faneroff's Care of the High-Risk Neonate is an approachable text for resident physicians rotating through the NICU. Additionally, Neo Reviews is an AAP publication that can provide good overviews of specific neonatal conditions and is accessible through the WVU Internet. The monthly schedule for when you will take your days off is determined by you and your team. Work with the ICU fellow to create the schedule so that a NICU fellow or senior resident is always present for rounds as much as is possible. This is important to provide first-time rotators through the NICU with a resource for assistance throughout the day. While the NNP team is always present and more than willing to help, it is an important function of more senior trainees to assist more junior learners. As a team, rotate which resident will stay late until evening checkout. A word on duty hours. As this is an ICU experience, expect to work the hours that patient care requires. The NICU rotation will adhere to duty hour guidelines such that you will work a maximum of 80 hours per week when averaged over a 4-week period, and that you will get at least 1 day off in 7 when averaged over a 4-week period. Even if you were to work 12 hours a day every single day you came to the NICU, this would still only equate to an average of 78 hours per week in a 31-day month with 5 days off per month. However, if you are in danger of violating duty hours, let your senior resident, NICU fellow, and/or attending physician know so that accommodations can be made. As you approach your month, I would encourage you to engage the nurses, RTs, and NNPs. They have great experience and are a great resource to aid in your learning and improve your experience in the NICU. Don't be afraid to ask questions to them or the fellows or staff physicians. Take time to synthesize the data about each patient into an assessment of their problems and develop a plan of care. Don't just report the data by reading it off of your rounding paper. Seek out procedures and actively participate in deliveries. Don't miss your required conferences or clinics. Lastly, spend time talking with the moms and dads of the babies. This is important to do for them and to push your understanding of what is going on with each patient. Don't forget to check up on your patients in the afternoon after rounds. Many have an evolving clinical status that does not wait for rounds the next day. We hope that you have a great month working with us in the NICU. The staff, fellows, NNPs, nurses, CAs, desk clerks, care managers, social workers, pharmacists, dietitians, and respiratory therapists chose to work here because we love the NICU and taking care of the babies here.